Yes. Introduce myself. Okay. My name is Marlena and I am a nurse residency program director in Montana. So I started out knowing that I wanted to work with people in some capacity. I think I started off going down the path initially as looking at psychology, but quickly shifted to social work and actually went down that path for a long time, made it into my very last semester. I was working at an intensive therapeutic group home for boys, but really got to the end and really just felt that that type of work, the solutions were so ambiguous. Like there were so many problems and everything seemed so convoluted that I didn't feel like I could ever get to that place where I felt like I was truly helping people and kind of closing the loop. And so I ended up making a big shift and went to nursing because I really felt that it had more of that science to it. I'm very much a science brain. But there's a little bit more of that algorithmic type of approach to nursing to really help people in the end. And so after time, I found the finesse, I found the art to it. But starting out, I really needed a little bit more of that structure. And so that's kind of how I ended up in nursing because I really wanted to help people. But I also come to it with a kind of scientific engineering brain. And so it just seemed like the natural transition. I think naturally, I always like math and science as a child were always something I really loved to do. I grew up in a maybe the wrong term, broken home, but ended up with two parents that got remarried, had several, stepsisters, siblings, half everything, just a really blended family, and kind of watching people go through those transitions as the youngest one in my family. I got to really see kind of human nature at its most vulnerable and seeing where people could really use that help, which is why I had that draw to social work of really wanting to kind of look into family systems. But there was that piece of me that was a little bit more technical and needed a little bit more of that scientific approach. And so that transition into nursing seemed like a really good blend of those two things. Yeah.
Doing these things.
Yes, because I think, at the end of the day, nursing truly is based in evidence. Everything that we do should be one for the patient for safety and quality of care. And the only way that we get that is by making sure that the practices that we have are rooted in evidence and are rooted in what we find are best practices. Mm-hmm. Yeah, the role that I play as a nurse residency program director, it puts me in a unique place to be able to kind of see what we like to say behind the scenes and behind the curtain on all components. I work day in and day out with brand new nurses, helping them to navigate the profession, navigate the department or specialty that they're working in. But so much of our work too is learning how to navigate the leadership landscape and be able to kind of have, my customer is both the new nurse, but also making sure that the leaders of the departments have what they need when it comes to bringing in new nurses. And so, we get to kind of see behind the curtain and see all of the struggles that our nurse leaders are facing when it comes to productivity, it comes to staffing, it comes to all of these different things, them being at, way over capacity with the workload that they have and not feeling like they have maybe the skills, the time, or the resources to give to the new nurses. But at the same time, we're there, boots on the ground with these new nurses who are feeling the impact of all of the things like short staffing and their leaders not being available. And so, being in that position, I think one of our biggest challenges that we have right now is bridging that gap of our nurses coming into the practice from the academic setting. They get so much exposure to a lot of little components of nursing and they get all of the textbook data, but they walk onto a unit, maybe a pediatric unit, and they know this much about being a pediatric nurse because they've just spent the last 2 or 4 years experiencing a little bit of every facet of nursing. And so they come onto these units with, one, they don't have the skills to do that specific job completely, but they also don't have any of the components that they need to be a great, experienced, competent team player, like the communication skills or knowing what it means to have interdisciplinary collaboration and all of these things. They're just trying to survive. They're trying to get through their first shifts without killing somebody. And so it creates kind of this hard dynamic for the new nurses, but also for the leaders that are trying to keep these teams safe. It's a tough place to be.
Not the case. Is that what you're saying?
Yes and no.
Okay.
They come out of nursing school with the foundational knowledge and some of the skills to be a nurse, but not to be a pediatric ICU nurse. And so that's why residency programs are really good, because my job is to help make sure that the brand new nurse that's being put on the PICU, pediatric ICU, it has all of the right components, to move through their orientation, to make sure that their teams are communicating when they're seeing that maybe they're not moving along an orientation the way that they need to. What are their gaps? What are their hangups? What are the areas that they can't get past? Or what are they doing really well? How are we making sure that the team is giving them the feedback that they need? So it really is a challenge that you see, I know, across the country, but it's a whole other topic to get into of like what are all of those things that put the brand new nurse in this position? I can go down a whole other. Basically, what we see is a residency program is coming in to fill the gap that has naturally evolved. So what we see right now, like we talked about in the podcast this morning, what we're seeing with our new nurses is they're coming out of nursing school with the nursing programs doing the best that they can to expose them to all of these skills that they could potentially use as a new nurse. But they come onto units where we have what we call a loss of deep knowledge after COVID, where experienced nurses have kind of left the bedside. We have seen that was hastened along with COVID. I know I spoke personally to several nurses who maybe were thinking about retirement, that when COVID happened, they were like, this is a good time to leave. So we saw that, but we also saw a lot of mobility start to happen within the nursing profession. So people leaving units that maybe they were on for 3, 4, 5, 7, 10 years and looking for a new experience that maybe fit them a little bit better. So what you end up having are these holes on these units where you used to have a lot of experienced nurses. Now we have holes. Well, now we have all these new nurses and we're like, we can put you anywhere. So we train them, we do the best that we can, but then after a year or two, we still have this same problem. Now you have a 1-year nurse that's now training the brand new nurse that's coming on. And so you have less and less of what we call that deep knowledge. And so we get into this conundrum where there's not those human resources on a unit. And then you add on the fact that nurses, their scope of practice is increasing, it seems like monthly. The more documentation that they have to do, the more responsibilities. Patients are sicker. They're going home sooner. So nurses are having to do more to prepare that to get them home. A medical unit, nurse is doing a lot more than they were 10 years ago for a patient on that unit. So then you add on the fact that our nurses are coming out of nursing school where they just went through high school and college in an age where texting is a really main form of communication. And so they're not experiencing a lot of those adult in-person, communication skills like maybe we were 10 or 15 years ago. So you put all of this stuff onto a unit where then you also have people struggling with staffing issues, and you have a brand new nurse that is not given the tools to succeed. They are given the tools to not succeed. And so our job as residency programs are to come in and say, whoa, like, let's advocate for their needs. Let's make sure that we can start putting protection around this orientation process to make sure that they can get what they need, and to advocate to our teams and educate our leaders and our preceptors and these people to say, look, these are the challenges that are facing new nurses. It's not that they have less critical thinking. It's not that they don't know how to be resilient. It's that we're putting them into environments without the right tools. And that's kind of the challenge that we see as one of the biggest, at least in my world, that's one of the biggest challenges that we see. Yeah, no, that's a great question. I think that there's two things that we have focused on that we think really does make a difference because we see it in our team dynamics and interactions. And one of them is we do a 3-hour course on just communication styles and understanding emotional intelligence and personality styles. Really having people understanding the different dynamics on their team and the why behind people's personalities and their kind of, base ways of interacting with people. We spend a lot of time talking about, what that means. Like, what are your, are you extrinsic? Are you intrinsic? We use these different personality assessments, and it really opens a lot of dialogue for them to start exploring. Like, maybe this is why this person may be standoffish. It may not be because they're, trying to have a cold shoulder to me, but maybe they're just a little bit of an introvert. And I, as somebody who's part of this team and need feedback, I need to work on advocating for myself and asking for this feedback instead of sitting back and saying, well, I'm not getting this feedback. Maybe no news is good news. Maybe no news is bad news. I'm not really sure. But the other thing that we've implemented that I think a lot of places could benefit from is we have an interprofessional dialogue. Basically, we just call it a how to talk to providers class, where we have physicians, we have surgeons, we have advanced practice providers come and sit on a panel and talk with our brand new nurses. They spend the first 30 to 45 minutes talking about what it looks like to give report to a doctor on night shift, or, how you kind of navigate those conversations. But very quickly we get into what are their kind of vulnerability points? What are their biggest fears about communicating with providers? And having those providers share real life experiences with them really humanizes that relationship and takes a lot of that fear away from them. So when it is 3 a.m. and they're calling a doctor for the first time, they have a little bit better understanding of what to expect and how to navigate those conversations. That is protected time off of the unit that they have in a class with us.
Okay.
We have spent an incredible amount of time advocating over the years to our leadership team by knowing how to speak the business of healthcare and coming forward and say, look, if you give us this protected time with them, we promise there will be a return on your investment, because here are the things that we are working on to improve communication between teams, streamline our operations, really focus on some of those quality and safety components. And honestly, we've been thankful to have a team that is supportive of those measures. And I feel like that's the biggest piece, is having leaders that trust us when we say, this is what they need. This is what the evidence shows that we need to put more emphasis on, are giving our new nurses the resources and tools that they need to survive on the floor. I think it's a combination. I think for us, what we have found to be most meaningful is to look at both, what does the evidence say? So it is, doing literature searches and understanding how to interpret your data and how to pull it forward and say whether this is high quality or low quality. That's what you start focusing on as you go into more of those advanced degrees, the DNP, the research. But, at a basic level, when speaking to some of these teams, these leadership executive teams, that they just want to know, what's the data say? And we can say, this is high quality data that we can show, but it's also our own anecdotal information and also what we are experiencing with our internal data. We work hard to do a lot of surveys and gather a lot of different data on our nurses to be able to come back to our team and say, this is what the literature is suggesting, and this is also what we are seeing with our teams. I think that we have a pretty strong case to say this is the way that we need to move forward. We need to advocate for more in-person, class time, debriefing time, mentorship, offering those different resources to their nurses. So for us, I think it's a combination of both. I think it's both. I think you see organizations and systems working so hard, rightfully so, to streamline efficiencies and operations and, and improve the way that our flow goes for the layman person. But really, I think a lot of the efforts that get put out, there's not enough voice from the nurses on the ones that are at the bedside, the ones that are actually doing this work that are going to be impacted. It seems to work best when leadership teams and organizations are really asking for their input when designing or implementing new projects or processes. It's those ones that aren't hearing those voices to say, if we are going to renovate this unit, like how do we make sure that the unit is laid out in a way that's going to work for the staff, and they're not going to have to triple their steps to get the resources that they need that maybe they use 7 times a day. How do we incorporate those end users into those processes more? I think that we could see a lot more progress in that.
Today.
Gosh, I go back to the conversation about like nurses having, so many options. Nursing really does have a lot of options. I feel like it's endless. But what I have found is that I feel like it gives you this space to develop a purpose. So often there's this author that I really love. Her name is Angela Duckworth, and she talks about grit so much. And I've learned so much from, her teachings and some of the research that she's done. But, she talks a lot about the difference between passion and purpose. And I think one of my favorite things about nursing is that you can come into it with a lot of different passions. And you have the ability to explore those passions, but it takes time to develop your purpose. I think we come in, we see it so often with brand new nurses will come in, they get this idea in their head that, I want to be an ER nurse. It's what, from the minute I started nursing school, this is what I wanted to do. I do all the work, I get into it, I get hired onto the ER, I come to it and I hate it. And I hate it, but I'm terrified to admit it. I don't know how to admit it to my family. I don't know how to admit it to myself. I built this identity. I said, this is going to be my purpose in life. When in reality, that's what you thought your passion was, is to have the excitement and to be that nurse that's, making critical decisions. And it's okay to explore those. But I think that nursing gives people the space to find their purpose. So there's ways that they can move throughout the profession and try different things until they get to that place where both their life experiences and the things that fill their cup start to come together. And then that's when they can find that true place that their purpose is. And I feel like that's what happened with me. I loved floor nursing. My background is in surgical oncology, loved my patient population because we really focused on that recovery and trying to find hope after going through these really big kind of traumatic events and surgeries that were, hopefully going to bring a new path for them. But it was hard for me as I started to make a family and being away from my kids, and trying to work these night shifts and 12-hour shifts that, I finally had to make a move into professional development and education. But I found that when I did that, I was able to see that I was still helping patients by focusing on developing these new nurses, and then started to find kind of the areas that I really loved and got passionate about, but they really started to develop my purpose. And that's what I think nursing. Yeah. I think what, we ask the question, what do we want to see change in nursing, or what do we wish people knew about nursing? I wish new nurses before, as they're entering into, schooling to become a nurse, really having real life conversations with nurses to understand what it's actually going to be like. Because so often we see these new nurses come in and they're saddened and they're a bit heartbroken to see that the work is so hard. It is so tough to become competent. It's so hard to find a team and feel supported. And the work is often not pretty. You're not saving lives every day, and so these nurses come in and they're just like, what have I done? and we see them want to say, I don't know how I'm going to do this. And so, part of the role of a mentor and a leader is to really be able to sit down with them and figure out what those desires are. Where, I can have a conversation with 2 nurses and they can be on 2 completely different paths in their life, working on the same unit, wanting to leave that unit, but for very different reasons. And so a lot of the discussions that we have with some of our nurses is saying, we come in thinking that sometimes we need to chase that passion. I want to be an ER nurse or bust, and I'm going to do anything I can. I'll work nights, weekends. I'll, work the overtime. I'll do whatever I can to get to that. But then there's other seasons in your life where you are saying, I want to come to work. I need a steady paycheck. I need the insurance. I will compromise not doing my passion, which might be that ER nursing, but instead shift to something that's going to allow me to have the work-life balance or to raise my family and shift into balancing motherhood and this profession. And so maybe it means I need to move to a clinic, or I need to move to a place where the hours are a little different. And I think if we took more time to have those conversations with these nurses that are at a year mark, or they come in and they're trying to start a family and they're like, I can't do this. If we really took the time to sit down and ask them, what those paths look like and help to curate that a little bit more, you see a lot more retention. And that is what we see when we take the time to talk with our nurses and find out what truly is the piece that's making you want to leave.
Get people out of a program.
Absolutely.
As well as bringing it in.
Absolutely. I think it's a critical component for leadership teams, for educators, for mentors, is to be asking those questions of what do you want to be when you grow up? Or what, that's a question to ask. Sometimes you come in and you don't know what you want, or you're in a position where you're at a transitional stage in life, starting a family or whatever that looks like. If we want to retain people, we need to be able to find out what their needs are, and we need to be more agile in being able to meet them where they are. So, I think spending the time to really look at stay interviews instead of just exit interviews. When we're doing annual evaluations, are we really truly asking, like, what do you want to do? And if I'm the leader of a unit, it can be really challenging to have those conversations of, how do I help you transition off my unit and now I have another opening? But that is the way that we keep people, is if we're having those conversations of, how do I meet you where you are in your life so that you can remain a member of this team? And sometimes we have to make those decisions to help people get where they want to be. Yeah, as a residency program director and coordinator, my role is a little bit more off paper, but we do a lot of work with teams, with charge nurses and supervisors, managers, directors, of helping kind of bridge that gap a little bit. Sometimes we'll have new leaders that come to us and they say, hey, man, this new nurse is really struggling. We're doing what we can. Sometimes our job is to help facilitate the reflection for that leader to say, are you making sure that your teams are giving real-time feedback? Are you making sure that you're checking in with this new nurse on a weekly basis to see how they think their progress is going? Are those things aligning? Is the feedback the same? Are we on completely different pages? And this is really more of a cultural issue of somebody wanting to eat their young. Like, what are we dealing with? And then also helping them to script those conversations. Because what we find over and over and over again is, even for new leaders, it's really hard to give feedback in the moment. People will typically avoid giving feedback in the moment unless it's more of a critical issue. And so if we can be using more of the resources out there to teach our teams how to give real-time feedback, we could alleviate a lot of the stress that we face with not understanding where our teams are. If we understood what their struggles are now and we're working to fix those in real time, we don't have to wait till annual evaluations come. But as a residency program director, my job actually comes more for helping people, coach them into how to give that feedback in compassionate but direct ways. And then also teaching our new nurses how to receive that feedback and not internalize it. Instead, like, how do I use this to help me to grow in my practice? Mm-hmm. Money for resources, more money for more staff, more money so that we have more time, more money to invest in, our technology. I think so many of the issues that you have facing nurses today that are increasing some of those risks, those adverse events, all of those things, a lot of it comes down to the time and resources that we have at our fingertips, because nurses are constantly out of time and don't have enough resources. Yeah. So mine was a difficult code. I was brand new to, it's kind of like a charge nurse role. We were shift unit supervisors. But it boiled down to me not understanding the difference between when it came to the resources, the different resources that came on a rapid response team versus a code blue team. And what that meant was I had a patient. I work in an area where we take care of patients in rural areas. So on my surgical oncology unit, I was the shift unit supervisor for the night. We had a patient that was traveling 3 hours, who had been known to our surgical oncology team. She's one of their patients, had esophageal cancer, and was coming for surgery the next morning, but she refused to get, ride by the ambulance, was being driven by her husband. And we were told that she was having pretty profuse hemoptysis, which is like you're spitting up blood. But she had been stable for the day, her vitals, everything. Her husband had been taking care of her. She was traveling. And so we were preparing for her. Our provider said, let me know when she's there. I'm just a few minutes away. When she gets there, I'll come in and assess her and get her settled for the night. And we'll go first thing in the morning for surgery. Patient came in. It was right around shift change, helped to get this patient settled. And because it was shift change, they weren't assigned to a nurse. We were going to give them to the night nurse I was a day nurse at the time, was going to give them to a night nurse that was coming on. And this patient came in and was spitting up blood into a bag. And we were in a room with a couple of our staff getting her situated with her husband. And I stepped out of the room to grab some supplies and came back. And at this point, she was leaning forward and she was starting to kind of cough and starting to have some difficulty breathing. So we called a rapid response. I was on the phone with the provider saying, she's here and, we're struggling a little bit. So we called the rapid response. And what I didn't realize by calling the rapid response team at that time was, because the rapid response is when you're calling for kind of an urgent situation, you need eyes on a patient, but maybe they're not coding, it's not an emergency yet. What I didn't know is that the flight nurse does not come with a bag with all of the additional trach supplies. We have a cart that comes to the room and there's a couple in there. So we have one of our intensivists show up. We have an ICU nurse. We have all these people. And as she was kind of rapidly deteriorating, and I said, do I need to call a code? And they were like, no, we're already working on this. But what I didn't know is that we didn't have the resources that I needed for this patient. And so when they started screaming for the other supplies and we didn't have them, it was a bit of a frenzy. And by the time we called a code to have them bring the instruments, the patient was already on their way up to the OR and she passed away before they could get her into surgery. And so it was one of those moments for myself of, learning what it means to be vulnerable and to say, I don't know what we need here. I need somebody to help me make these decisions. And I think, hesitated a little too long, and it ended up with a patient dying on my watch, and as a young new leader, that's a really hard thing. And so kind of cemented in my head. And what I really try to push for our new nurses is understand your resources, know where to go to find this information, and ask the questions, question everything. Have a spirit of inquiry in everything that you do. And if you don't know something or you feel uncomfortable with a topic or you feel uncomfortable with a procedure, those are the ones that you need to dig into. Get uncomfortable, make yourself uncomfortable, and learn what you need to know so that you can close those own gaps in your own. But I think that's what I talk about when I say finding your purpose. It's those life experiences that you have that lead you to finding what your real purpose is in nursing.
Yeah.
And I because of those experiences and because of my desires and my passions, I have found a role that I won't ever leave. I may not be a residency program director, but the nursing professional development will be the route that I go because of those life experiences and what motivates me now.